Good morning, everyone. I welcome you to yet another edition of the Vitreoretinal lecture series, anchored by the Kunle Hassan Eye Foundation Academy. This is the fourth lecture in the series today that we'll be taking, and we'll be looking at the topic Vitreoretinal interface disorder. I'll quickly go through the program. I'm doing the welcome and introduction. Afterwards, we'll listen to the presentation from the speaker. Then we have the interactive Q&A session and the closing remarks. So I'll give a brief overview of the Kunle Hassan Eye Foundation Academy. This is a part of the Eye Foundation Eye Care System, formerly called the Deseret Community Vision Institute. He oversees the training of ophthalmologists. Please, I ask that if you are not speaking, can you please mute your microphone, please? If you are not speaking, can you please mute your microphone? Thank you. It oversees the training for ophthalmology residents and fellows, middle-level ophthalmic practitioners, optometrists, and ophthalmic nurses. Today, our speaker is Dr. Michael Jesse. He is the Chief Executive Officer of St. Thomas Eye Hospital in Accra, Ghana. He's also a vitreoretinal specialist. He is the immediate past president of the Ophthalmological Society of Ghana. He has authored more than 30 peer-reviewed publications. Hello. Please, can you mute your mic if you're not speaking? Thank you. He has authored more than 30 peer-reviewed publications, a book chapter, and a regular peer reviewer for the Indian Journal of Ophthalmology, PLOS ONE, Africa Health Sciences, Case Reports in Ophthalmology, the Ghana Medical Journal, and Annals of Nigerian Medicine. He is on the editorial board of the Nigerian Journal of Vitreoretinal Diseases and has served as a technical advisor to the Wellcome Trust of United Kingdom and Ugochi Memorial Research Institute of Ghana on research and grants, on clinical trials application respectively. He was the lead research ophthalmologist for Ghana Onchocerciasis OCT study and IDA clinical trials funded by the Bill and Melinda Gates Foundation. He has been a regular speaker at the annual Global Health and Innovation Conference at the Yale University in Connecticut, USA since 2008. In 2010, Dr. Jesse, he was elected by the World Policy Journal as one of 5 eminent African physicians to discuss the big question, brain drain in Africa. That same year, he served on 2 panels of the World Glaucoma Association African Glaucoma Summit in Africa, where he saw Dr. Adekunle Hassan for the first time. He is an alumni of the Kunle Hassan Eye Foundation Academy, where he obtained his Vitreoretinal Fellowship. He is a member of the West African College of Surgeons, the American Academy of Ophthalmology, American Society of Retina Specialists, and Fellow of the International College of Surgeons. I would like to welcome our speaker, Dr. Mike Jesse. Quickly, I would like to inform the House too as well that please, if you are not speaking, please mute your mic. And if you have any questions, you can raise your hands or leave them in the comment section. This lecture series is being recorded, so we asked for you to turn off your camera so that we can get maximum optimization from the lecture today. Dr. Mike Jesse, we welcome you. Thank you so much.
Thank you so much, Frances. I hope everyone can see my screen, which is being shared now. Frances, can you see the screen?
I see you, but I don't see your slides.
Okay, let me see if I can reshare it. Can you see it now?
Not yet. I still
Not
see.
yet.
I still see you. Yes. Please, can I ask Dr. Nasiru to please turn off your video, please?
Can you see the video is on?
I can't see it yet. I don't know if you want to try turning off your video and see if we can see if your screen will come up.
I'm trying to turn it off. It's not turning off. Let me see. Okay, video is off.
I'd like to appreciate everyone for joining. Please just bear with us while we'll try to get the slides up and running from our speaker. Thank you so much.
Is the screen visible now?
Not yet, Dr. Jesse.
Hey. I think my screen should be on. Francis, are you able to see?
Yes, I can.
Okay, so that's it then.
But not your slides. I can see your email, your inbox.
And you can see my slide still. Now the slide is fully on.
What I see is your inbox, access to your inbox. Would it help if you share your slides with us so we can project for you while you're speaking?
I
In the
can
interest
do that
of time.
well.
Okay. Thank you so much.
I'm sharing from my Dropbox.
Okay. In the meantime, you can stop sharing your screen because what we have on is your inbox up.
Right.
Please, can you see my screen?
Yes, we can.
Okay, I'd like to apologize to everyone for the little technical delays. We'll start off now. Dr. Jesse,
Yeah,
please over to you. So if you can prompt me when to move to your next slide.
So that's okay. So thank you so much, Francis, and to everyone. I'm so sorry. I'm so sorry for the mishap, maybe because I've been using Zoom for some time. And I thank the organizers, and especially Dr. Hassan, for this privilege to be here and share my thoughts with you on the topic of vitreoretinal interface disorders. I understand I have only 35 minutes, so I've set the clock and look forward to being able to deliver this in time. Can we have the next slide? There's no disclosure no financial disclosure, except that Dr. Hassan continues to be my mentor. Dr. Okonkwo is my great teacher, and Dr. Odenolo, of course, my pastor. Can we have the next one? Next slide, please. Next slide. Okay, so over the past few years, we've been talking about all our teachings have focused on vitreomacular interface disorders, but we've come to the realization that the disorders that we see in the retina is not only limited to the posterior pole, and as such, there's a growing interest to look into vitreoretinal interface as a major set, with the VMIs being a subset. So what is the vitreoretinal interface? There's a boundary between the vitreous cortex and the internal limiting membrane. Between these two components is extracellular matrix that acts as a binding glue that holds these two tissues together. The ECM is made up of proteoglycans, fibrous proteins, and that include laminin, collagen, and fibronectin. Can we have the next one? Next slide, please. So now let's look at the cortical vitreous, largely made of type 2 and type 9 collagen fibrils that are arranged in a beautiful lamellar pattern. And this lamellar structure can be seen in the histochemistry slide above, or in the high resolution 3D OCT below. It is thin over the macular area and absent over the optic disc, giving rise to the wise ring that many of us have seen in the clinic before. And embedded in the posterior cortical vitreous are hyalocytes. We will understand these structures and these arrangements as we move on. Next slide, please. Hyalocytes are essentially mononuclear cells that are known to synthesize the vitreous collagen, glycoproteins, and also synthesize some enzymes. They have dense concentration in the vitreous base, followed by the posterior pole. The lowest concentration of hyalocytes is in the equatorial regions. Can we move next slide? The internal limiting membrane, which we've all seen and learned over when we medical school, is a multilaminar structure that acts as a basal member of the molar cells. We know this from basic sciences. Like all basal membranes, it contains secretory ECM proteins like fibronectin and proteoglycans, which can be seen in the pictures on the right-hand side. Other proteins are collagen that are more on the vitreal side, and laminin, which is more abundant on the retina side. Unfortunately, I can't show this. Can we have the next slide? The regional variations in the vitreoretinal interface in terms of thickness in different regions of the retina. These thickness variations are related to the thickness of the ILM together with the density and orientation of the cortical vitreous fibrils. These underpin the differences in disorders that are seen in the various regions of the retina. Can we have the next slide? So we're going to look at the peripheral retina, look at the macula, look at the surrounding blood vessels, and take a little look at the optic disc. Next one. So let's look at the peripheral fundus. Mechanics and structures in this region are associated with peripheral disorders like lattice degeneration, which you can see on the top photo, white without pressure and the white with pressure. Others are meridional folds and meridional complexes that are all seen in the peripheral retina. We have retinal tufts that may also be cystic or non-cystic. Could you go ahead so we look at the others? Other disorders include traumatic and non-traumatic retinal tears that include giant retinal tears leading to rhematogenous retinal detachment. So in this context, we are beginning to see retinal detachment actually as a VRI disease because of this nature of the peripheral retina and the nature of this arrangement and the internal limiting membrane. Next one, please. Okay, so we also going to look at the structure of the vitreoretinal interface along the major blood vessels. The island thins out and sometimes become absent over the major blood vessels. At these points, probably can look at the pictures on the right-hand side. This is a histological slide. The central semicircular structure of the blood vessels, the pointing arrowheads are the internal limiting membrane, and the arrow is a termination of the internal limiting membrane, showing that the ileum doesn't get around blood vessels. It terminates at a certain distance from major blood vessels. And at these points, vitreous may become incarcerated directly into retina, becoming contiguous with the perivascular tissues. All these will be explained further as we move into disorders. Next slide, please. So such arrangements are associated with the following disorders in the peripheral retina. Occasional bleeds associated with spontaneous PVD. All of us have seen once in a while during PVD when the spontaneous PVD happening and the patient comes with a bit of, I saw some showers flowing from top down or from up down because there has been a little tear in the blood vessel because of this contiguous invagination or the vitreous around blood vessels due to the absence of the internal limiting membrane. In the same way, traumatic vitreous hemorrhage and vascular avulsion, when there's trauma, apart from some patients developing, Valence edema, and there are a few cases where you have vitreous hemorrhage, and this happens because the vitreous directly contiguous with blood vessel perivascular structures, and trauma with that valence can shear off a bit of the blood vessel wall, leading to hemorrhage and in the vitreous. The same way vessels can become completely avulsed during trauma. And it also underscores why sprouting new vessels readily gain access to the vitreous in proliferative disorders like PDR, PSCR, AMD, neovascular AMD, among others. Because of this gap, the internal limiting membrane does no longer serves as a barrier. So sprouting vessels are able to pass through into the vitreous, creating the cascade in the vitreous that you always see in proliferative disorders. Can we have the next look? Next slide, please. Okay, so VRI disorders along major blood vessels at the same time, this arrangement contributes to glial cell proliferation, with glial cells gaining access from the retina onto the internal limiting membrane and proliferate to cause surface wrinkling pathologies like epiretinal membrane. So again, because of this gap here, glial cells from the retina can actually move inwards and they proliferate on the internal limiting membrane. And this is not one of the causes of epiretinal membrane formation. Next slide. So let's look at the optic disc. We mentioned already the interface deficient over the optic disc as it terminates at the edge of the disc. And this attachment is actually very strong and underpins why surgical induction of PVD is done in the way it is. Anyone who's been to theater to see VR surgeons inducing a PVD during palpebral vitrectomy will notice that we don't put the cutter at the center of the disc. We put it towards the edge of the disc so we can suck in with the hole pointing outwards into the vitreous. This allows us to suck the vitreous into it, and they begin the process of separating this vitreous from the margins of the optic disc. The same attachment may remain during anomalous PVD, providing a tangential tractional force that may result in macular hole formation. In other words, sometimes during spontaneous PVD, you don't find this fully detaching from the optic disc. And now we know that macular holes have two mechanisms: the anterior posterior tractional force and the tangential tractional force. These tangential forces are actually, they do happen because you have vitreous that is still attached to the optic disc, and they provided this tangential force towards the fovea. Can we see the next slide? So now let's look at anomalous PVD, and then let's take a look. This anomalous phenomenon is a common denominator in most of the disease processes that occur at the vitreoretinal interface, especially in the macular region. So let's have a recap into what PVD actually is. It is a spontaneous, age-related, orderly process that results in vitreous liquefaction, alteration the ECM, and a beautiful separation between the vitreous and the retina. That's what spontaneous PVD always leads to. Very beautiful separation. So the vitreous and the retina break their relationship, and each of them goes their way. In anomalous PVD, however, this happens when vitreous liquefaction exceeds the degree of vitreoretinal separation. So you see areas of vitreous maintaining strong attachment to some areas of the retina, and this leads to so many pathologies we see in the peripheral retina and on the posterior pole. Can we have a look at the next slide? Again, at the retinal periphery, anomalous PVD may result in retinal tears and detachments. Many of us have seen what is spontaneous detachment. We haven't induced it. This is a PVD happening, and you see retinal tears associated with PVD. And many of the studies, even in Knight Foundation, have shown that majority of rheumatogenic detachments happen in elderly people. It happens because there's a detachment of the posterior vitreous, and this detachment, areas of the adhesions may become torn, and with this vitreous which is now liquefied, passes through this tear, leading to retinal detachments. In the macula, it causes vitroschisis that may lead to a PACA, a VMA, VNT, or a macular hole formation. It may also contribute to some of the cases of the diabetic macular edema. At the optic disc and retina, it causes vitreopapular retraction, which we mentioned already, and this may promote optic disc neovascularization. Again, because of the anomalous nature of the detachment, you still find vitreous attached to the optic disc, and this allows cascading of blood vessels growing into this vitreous mesh, which is still attached. So it promotes neovascularization of the optic disc. Next slide. So let's look at the vitreomacular interface. Again, let's have a recap here. The posterior vitreous cortex is thinner over the macula and demonstrates a lamellar arrangement, like we said already. The VMI covers an irregular circular zone of 3 to 4 millimeter diameter set over the fovea. Activities in this region, including vector forces emanating from anomalous PVD, and that's caused many of the common disorders that we see in the posterior pole. We mentioned a few in the peripheral retina, and we're going to look at the posterior pole and some of the disorders that happen because of anomalous PVD or anomalous separation of the vitreoretinal interface. Can we see that? Next slide, please. So we're going to look at diseases like vitroschisis, epiretinal membrane, VMA, VMT, macular holes, and then probably just take a little detour around the others on the right-hand side. So should we go on? Next slide, please. So let's look at vitreous chisis. This is a split in the posterior vitreous cortex due to partial thickness dehiscence along the lamellar cortical planes. Again, we look back at the arrangement of the cortical vitreous. They are in lamella. There's always a potential cleavage, where separation may happen, causing the schisis. And schisis occurring anterior to the hyalocytes will usually leave a very thick cellular membrane attached to macula. And the presence of this membrane still attached to the macula lead to proliferation of hyalocytes along the island, including recruiting of glial cells, and together resulting in one form of epiretinal membrane or epica. Next slide, please. Can we have the next slide? So let's look at epiretinal membranes. And of course, again, in schisis, a few might have seen during PVD induction in surgery, where you think you have fully detached your vitreous. When you stay with transdural, they realize there's another layer of vitreous over your macula, usually over the fovea area. This is usually very difficult to detach, right? So it's not only a normal PVD, which is spontaneous, but occasionally in our own surgical induction, we've seen where you've not been able to hold the entire vitreous, but rather you've actually separated this vitreous along a lamellar plane. And this leaves another layer of vitreous on the retina. And this is why it's important all the time that even if you could see your vitreous or you believe that there's been complete separation, do a little staining of the retina and see if you have any left some vitreous there through schisis. And the main pathology is glial cell proliferation on the internal limiting membrane, proliferating, forming a translucent fibrocellular membrane over the retina. Other cells that are implicated in epiretinal membrane formations are RPE cells and hyalocytes, as we mentioned already. It usually causes distortions and impairment of central vision. Can I have the next slide? So again, we continue with epiretinal membranes. Contraction of the membrane produces distortions and wrinklings of the inner surface of the retina. Again, this is why it's important that when you leave during vitroschisis, when you leave the layer there, we don't have a full PVD induction and the separation of your vitreous, you could have some vitreous left on there and will proliferate and cause distortion in the vision of this young person. This is actually very common in younger patients. Severity of this defines some of the common names associated with ERM. And so we're looking at names like cellophane maculopathy, which is almost the same as another name for ERM. But now the common thinking is that we should use the word cellophane maculopathy or preretinal macular fibrosis when the symptoms are mild. And the surface wrinkling, retinopathy, or radial striae when there's moderate wrinkling or moderate layer of the epiretinal membrane, development of the epiretinal membrane. And then the last one that we are talking about now is to use the word macular pucker when it's severe. So should we look at the next slide? Again, on the epiretinal membrane, in severe situations, an epiretinal membrane can cause enough traction on the retina and producing a force that leads to macular edema. So in this slide that you're looking on the right-hand side, you have epiretinal membrane, which you can see that white layer on the vitreous side of the retina. And then you have this cystoid changes within the retina itself. So severe epiretinal membrane may be associated with the CME. Next slide, please. Sometimes the confusion arises when you look at a case clinically and then you ask yourself, is it a lamellar hole or is it epiretinal membrane pseudohole? We're going to look at that. So now let's look at the lamellar hole. These are mostly idiopathic and believed to relate to spontaneous dehiscence of the internal wall of intraretinal cells. This was proposed all the way back in 1975 by Gas, when he looked at systemic macular edema, complicating cataract surgery, what we commonly call Gas syndrome. They noticed that in some of them, they go further to form a lamellar hole. The conclusion at the time is that the internal wall of this systemic changes actually break down and it leads to a lamellar hole formation. The defect is in the inner fovea with an irregular fovea contour, which you can see on the slides on both sides. They usually remain stable in visual function, and if they progress at all, it is very slow progress. And this also underscores why you don't really have to chase lamellar holes trying to peel to close, especially if the patient is good. It probably be safer to leave the patient stay wherever he is than try to chase it and then try to close it. The intraretinal splitting, which is schisis, typically occurs between the outer plexiform and the outer nuclear layers of the retina. Maintenance of an interphotoreceptor layer, and this underscores why vision is usually relatively good, because all of these can see that the outer retinal segment where the photoreceptors are located is actually not affected. So vision lamellar holes are usually reasonably good, and it's good that we do not interfere so much with them. Next slide, please. There's increasing debate over this, over pathogenesis of lamellar holes. And with the advent of OCT, role of posterior vitreous in its formation, again, is gaining more attention and traction here. So virtually everything is now about the vitreous and its relationship with the retina. It may now be seen to represent an abortive process of full thickness macular hole. And we will surely get to how full thickness macular holes happen. Lamellar macular holes may be tractional or degenerative. And now there are new classification systems and there are different schools of thought, and there's currently no consensus on how to even classify them fully. Some may have a retinal membrane over them, making them sometimes difficult to differentiate from macular pseudoholes. So let's look at what macular pseudoholes and how we can probably look at them in clinic and say this looks like a pseudohole rather than lamellar hole. So pseudoholes usually show sharply defined vertical macular contour on the central fovea. This is something described as verticalization. If you compare this, what you're looking at now, with the lamellar holes we see, there's a bit of a difference in the configuration of these holes. There's almost always a concomitant epiretinal membrane with a central opening. You can see the epiretinal membranes on these two slides. That is not always found on lamellar hole, even though we know that some lamellar holes may be associated with epiretinal membranes. The fovea, the central fovea thickness is almost always near normal, right? And there's no loss of retinal tissue in the pseudoholes. Can we have a look at the next slide? So let's look at VRI disorders in the era of OCT. We know current OCT technology focuses more on the posterior pole, but we are also hopeful with increasing development in the peripheral OCT. Some of these issues that we don't clearly understand. You're looking at why with pressure, why without pressure. You look at meridional folds, looking at lattices, probably will have a better understanding of how these structures actually really look like when they're histologically scanned optically. So let's look at the OCT issues that are being used in VRI disorders now. So in 2012, a team of experts was convened to come out with new ways of classifying the VMIs disorders. And this is because the OCT came changed our understanding completely. We moved from the gas system. We needed to standardize and find new classifications and new definitions for all these disorders that we knew in the past on the posterior pole. So these were solely to be based on OCT findings. Next slide. The classification was supposed to be simple, easy to use, easy to remember, supposed to be reproducible and standardized to enhance research. It's supposed to be predictive for intervention outcomes that may be surgical or pharmacological. And note that it was not based on clinical findings. It wasn't based on symptoms, and was not based on symptoms. It used one main classification and two subclassifications. In the context of macular holes, 3 subclassifications were used, and we'll see how to put this in practice. Can we see the next slide? So let's look at the classification parameters that were used. Under main classification, 5 entities, we don't want to say 5 diseases, 5 entities were identified. So we have VMA, VMT, full thickness macular hole, lamellar holes, and epiretinal membrane. The subclassifications looked at size of attachment. So in the new classification, we say attachment is focal if the site of attachment is less than 1,500 microns, and broad if it's greater than 1,500 microns. This is using size of attachment as a subclassification. Let's look at the next subclassification. So the second subclassification looked at the presence or absence of other macular diseases. So in this context, it says what you're looking at, this disorder you're looking at is isolated when there's no macular disease present. It's concurrent when there's other macular disease present. Then under macular hole, like we mentioned, 3 subclassifications were used. It looked at size of the defect, presence or absence of VMT, and whether it's primary or is secondary. And no, take note, this is not a staging system. This is not like the gas, it's not staging, it's descriptive and reproducible. Should we look at the next one? So let's put these new parameters into practice, because at the end of the day, we should be able to use these in our day-to-day clinical practices. Instead of saying there's an impending hole, there's whatever it is. So now let's look at what we have learned now and put them into practice. Should we look at the next slide? Okay, so vitreomacular adhesion. Under the new classification, vitreomacular adhesion is a detached posterior hyaloid which is seen on or above the retinal surface. Part of this detachment should be inserted into the retina within a 3 millimeter radius of the fovea, and that there must be no anatomic retinal change on OCT. This is usually almost always non-pathological. Should we go on? Next slide. Okay, so let's look at this slide below here. So we have a hyaloid, which you can see with the arrow pointing to. The hyaloid is inserted within a 3 millimeter radius, like we said. You can see it going to the center of the fovea. And the measurement of this insertion is less than 1,500 microns. And we can't see any anatomical change in the macular area under the fovea. So we say this is isolated because there's no other concurrent disease there. This is focal because it's set less than 1,500 microns. And this is VMA because there's no architectural change in the macular area. Should we look at example 2? So now look at this slide here. See the hyaloid attachment well away over the contour. Measuring, you can see the caliper there. It measures more than 1,500 microns. You look beneath the fovea, there's no any architectural change there. And then there's no concurrent disease that we can see. So because there's no architectural change, there's a VMA. Because it measures more than 1,500, this is broad, and because there's no concurrent disease, this is isolated. So what we have here is isolated broad vitreomacular adhesion. Should we look at the next slide? Okay, so this is example 3 that we can have a look at. So in this case, what we're looking at, again, the hyaloid is inserted in a way that is definitely less than 1,500 microns. We can see there's no real architectural change in the subfoveal macular area, but then you can see the subretinal fluid under it there, and this amorphous mass on the other side of it. So because it's inserted within 1,500 microns, we say it is focal. Because there's no architectural change there, we say it's a VMA, but because there is a concurrent disease, we say this is a concurrent focal VMA, and in this case, associated with the CSR. Should we move to the next one? So VMAs may have a number of progressive causes. 3 events may happen. They may resolve spontaneously, remain stable, or progress to form a VMT. So let's look at a VMT on the next slide. Definition of VMT is a VMA with any abnormal macular architecture. The slightest architecture there, it may be on it or within it, changes VMA into a VMT, and VMT is always pathological. It may or may not be symptomatic, depending on the change in the architecture or deformity of the macular area. So you look at the slide on the left side, it looks like a VMA, but when you look, see some little bump out there, which is attached to a hyaloid on the right side of the retina. These are mild ones and they may be asymptomatic. On the other side is this big one there with the obvious structural change, and this may be symptomatic. Should we look at it further on the next slide? So again, let's use the same parameters we defined and look what's happening here. There's a hyaloid which is attached centrally, less than 1,500 microns. There is an architectural change, and there's no concurrent disease. So this becomes a focal disease. A focal disease is a VMT because of architectural change, and it's isolated because there's no concurrent macular disease. Should we move to the next one, example 2? Again, here, the attachment is broad. You can see where it starts from all the way there. It's beyond 1,500 microns. And the hyaloid, there's a structural change in there, which you can see with the pulling of this in, and there's no concurrent disease in the macular area. So this is an isolated broad VMT. Should we look at it? Of course, this is not a very beautiful slide you will have wished to have because there's some amount of retinal membrane you can see there. Again, let's look at this one. You have a hyaloid insertion that is broad. You have a structural change. You can see cystoid areas there. You can see multiple retina changes there. You can see epiretinal excrescences on the inner retinal surface. They can also look at the outer retinal surface. There's what look like drusinoid changes over there, which you can see the bumping of the RPE, choroidal complex, Bruce complex. You can see the sternal limiting membrane also in a corrugated manner. So we say this is a broad concurrent VMT. In this case, it is with an AMD. Should we look at the next one? The cause of VMTs. So they may separate spontaneously with resolution of the symptoms. Symptoms get better. They may remain stable or progress to create severe distortions in the anatomy or lead to macular hole, which may be full thickness or lamellar hole. Next slide. So now let's look at full thickness macular hole and the tracer classification. We look at the size of the defect, presence or absence of VMT, and whether it's primary or secondary cause. Again, this is not a staging. Should we look at the next one? Okay, so let's look at size of defect. We say the defect is small when the full thickness retinal defect is less than 50 microns, medium when it's more than 50 microns and less than 1,400 microns, and large when it's greater than 400, sorry, medium when it's greater than 250 but less than 400 microns, and large when it's more than 400 microns. And these are things that are used day-to-day during retinal surgery predictions. You want to see the minimum distance between the two edges and all that. And we also know that the smaller the size of the hole, the better your chance of closure. And larger holes may probably require an inverted flap. Next slide. We are 35 minutes. Next slide. So we look at whether there's presence of VMT or no presence of VMT. So the first one is a full thickness macular hole with VMT present. The next one, full thickness macular hole, VMT released. Next one. Next slide, please. Okay, so again, the third criteria will be either primary, in which in the former case, we'll describe an idiopathic macular hole, or secondary, in which case it's associated with other retinal pathologies. You can see them trauma, surgical procedure, myopia, macular edema, etc. Next slide. And now let's look at the GAS classification, how this actually matches the new OCT-based classification. Let's look at it. Next slide. In the old GAS classification, where they have stage O, stage 1, 2, 3, and 4. In the new classification, the GAS stage O will be a VMA in the contralateral eye. And stage 1 is what we call impending macular hole, is a VMT classically. Stage 2 and 3 in GAS were all macular holes proper. So here we have full thickness macular hole that may be small or medium because the GAS one did not have measurements. Yeah, and the full thickness macular hole for stage 3 that may be medium or large, and stage 4 full thickness macular hole in the GAS when there's a PVD in addition. In the new classification, it won't be any of these with a VMT released. Next slide. So we've ended, and we did a few minutes above our time, and that's because of what happened. So thank you so much. And again, I'm sorry. The last slide had conclusion on, but I could not send that one under the situation that we had. So thanks to everyone for paying attention and then listening. I'm happy to see Dr. Hassan there. And once again, I'm sorry for the team issues that we had. Thank you very much.
Thank you very much, Dr. Jesse, for this very insightful lecture. We would like to take questions. If you have any questions, please raise your hand or you can type in the comment box. So we'll wait for your questions.
Should we have any contributions from some of our seniors who are still in the room?
Okay, we have Dr. Carey's hand is up. Dr. Carey, please, can you unmute yourself and ask your question, please?
Yeah, good morning. It's great to see Dr. Gessie on the chair this morning. And I just wanted to make a comment, and thank you for the new classification. I mean, some of us are not very fully abreast with vitreoretinal developments, so this is a good revision for me. And I also noticed that there's a question in the chat box. You might want to have a look at that and respond. Thanks, Dr. Gessie.
Hey, Dr. Fatima, how are you?
Fine, thank you.
Excellent. I hope Abuja is cool. You're enjoying Abuja. Thanks so much for the question. And let me see whether I can access the chat box here.
Let me read it out for you. The question in the chat box says, thanks for the presentation. Do you operate patients with VMI disorders? If yes, do you consider the symptoms as part of your criteria? Do you operate patients with VMI disorders? And if yes, do you consider the symptoms as part of your criteria?
Okay, so let's look at it this way. When we're walking through the VMI, we talked about VMA, for example, which is not pathological. It doesn't need any surgery. We talked about VMT that has a natural cause of being steady, resolving on its own, or progressing into a macular hole. We looked at the macular hole and said it might be full thickness macular hole, and it might be a lamella. We describe lamellar holes that they usually are stable, vision is usually good, and there's no real value going into it there. And now let's look at macular holes. You may have a small size macular hole, you may have medium or large size macular hole. The decision of surgery needs to be taken very carefully, taking into account the age of this person, because you need to bear in mind that when you go to the back, cataract will form early, and you may have to do that subsequent surgery, or you may take a decision to do concurrent surgery, take out the cataract, go out, and then try to peel your macular hole. In case of symptoms, you want to take into account a patient who is worried about the distortions in her vision, a patient whose vision has dropped, or a patient who so much want this hole to be closed. You want to do a proper counseling, considering the fact that you may still not have a hole closure, especially if it's a very large hole. You want to take into account the duration of this hole, the size of this hole, but otherwise, holes that are symptomatic and the patient can afford surgery should have surgery done, should have a hole closure done. I don't do inverted flaps. Dr. Konko is brilliant in doing inverted flaps, but we know in one of the papers that we did, the patient, despite all the controversies about inverted flaps, still improve in their visual functions. So the answer is yes when it's necessary and no when it's unnecessary.
I have another question from Dr. Ernest, and he says, thank you, Dr. Gessie. What are the pharmacological management of PVR and how effective are they? What are the pharmacological management of PVR and how effective are they?
She's talking about proliferative vitreoretinopathy. Is that what he's talking about? That's not what this topic is about anyway. But then he may want to talk to Dr. Okonkwo that new emerging pharmacological interventions from PVRs And of course, it depends on the staging. Don't forget, you have to stage your PVR before you decide on what you want to do. If you have a very bad PVR, say above C, like grade D, we are not looking at anterior and posterior segment classifications, looking at D with all the funnel shape configuration. There's no pharmacological issues here. But at the same time, I know Dr. Konko in our last chat is experimenting or actually practicing some of the pharmacological interventions. They are usually augmentations. If you're talking about pharmacological intervention in VMTs, that's a different thing altogether. In that, there are existing FDA-approved interventions using ochriplasmin, right? And of course, that also goes with the type of VMT, stage of the VMT, and there's enough evidence on those that are useful for ochriplasmin injections and those that are not. PVR and pharmacological interventions. Dr. Konko, I saw him in the house, might probably want to throw more light on it. If you ask my personal view, I do not do, but Dr. Konko gave me a very good briefing on it. I had wanted to try, but haven't started yet. So if Oji is in the house, maybe he may throw a bit more light on his pharmacological approach in augmenting PVR surgery. I want to believe he's not in the house.
I can't, maybe he's dropped out due to network issues.
I know it's about time to start clinic, yes.
Yes, I don't see him on.
No, otherwise,
okay, sorry.
If the question is in eye foundation, you should have a personal discussion with Dr. Konko, because I know he's doing. I will believe Dr. Denlaw will not be doing by now.
Okay, Mike, thanks.
Hey,
I think we've gone through a series of things. The best treatment for PVR actually right now is surgery. Pharmacologicals are just right now they are adjuvants. There are many studies over the past that looked at methotrexate, 5-fluorouracil, steroids, and a lot of them. Outcomes have not been really very, very, very encouraging. So basically now surgical intervention is still the best to make sure you get all the membranes out. But PVR, with such a question, I think I'll put PVR on the list of our next series of topics for this lecture series so that we can really spend some time looking at PVR. But personally, I had used 5-fluorouracil and methotrexate, and in the series of patients I didn't see any significant improvements or reduction in the post-operative PVR in retina detachments, which were the ones that we looked at. And if you want to look at ochriplasmin, I think you should go and look at the MIVI study. They give a summary of the categorization of VMTs that will do well with ochriplasmin. So I asked Dr. Obedo to look at the MIVI study.
Thank you so much, Dr. Okonko. And it's nice to have you in the house anyway.
Okay, do we have any more questions before we close? We're about to bring this session to an end. We would like to thank everyone for joining us. And once again, we apologize for the technical issues we had at the beginning. We usually have the Vitreoretinal series anchored by the Kunle Hassan Eye Foundation Academy every first Wednesday of the month. So we'll be having our next lecture for the month of April, and we'll be circulating the details to every one of us. And we really appreciate Dr. Jessie for taking out the time to join us today to have this lecture. We have a YouTube channel for the Konya Hassan Eye Foundation Academy, so this lecture would be uploaded within the next 1 week, so you can always go there and follow our channel and watch some of the previous lectures we've had in this series. Thank you all once again for joining us, and we appreciate you and look forward to you joining us then next month. Thank you.